On today's episode of Sports Medicine Weekly, we talk about the new recommendations on daily aspirin to prevent stroke and cardiovascular disease. What risk is there? What does aspirin actually do? And also, we'll talk about the new recommendation and how it plays into Dr. Cole's role as a surgeon. But first, JRF Ortho partners with orthopedic surgeons to improve the quality of life of patients by enabling them to have an active life through the generous gift of cartilage and ligament transplantation. Please go to jrfortho.org to learn more. Sign up to be a tissue donor at donatelife.net. This episode is also brought to you in part by Karen Malkin and her new protein brownie bar and superfood bars. Best tasting bars on the market, certified gluten-free, paleo, no added sugar. Karen's protein brownie bars and superfood bars available on Amazon and at KarenMalkin.com. Dr. Cole, some interesting stuff out recently as the U.S. Preventative Services Task Force considering making several changes to its guidance on taking a daily aspirin to prevent heart disease and stroke. Now, recently, the task force posted a draft statement recommending that adults ages 40 to 59 who are at a higher risk for cardiovascular disease but do not have a history of the disease decide with their clinician whether to start taking aspirin based on their individual circumstances. You know, this is the first time the task force has recommended that adults in their 40s talk to their doctors about whether to take aspirin for heart health. The draft also says that adults 60 and older should not start taking aspirin to prevent heart disease or stroke because new evidence shows that potential harms cancel out the benefits according to the task force. So it's interesting because for years and years, we were told, maybe it was recommended, Dr. Cole, to take a baby aspirin or a low-dose aspirin that could prevent stroke or heart attack, and now all of a sudden a switch. So let me ask you, what risk is there?
Steve, it's an interesting evolution on what sounded like a very simple thing. How bad can an aspirin be? Just take we used to call it a baby aspirin, but it's a low-dose aspirin. We don't call them baby aspirins because you don't want to give aspirin to babies. It's not indicated for anyone really even below the age of, say, 12. That being said, the risk has always been that heart disease is the leading cause of death in the United States. In fact, it's responsible for 1 in 4 deaths. So while taking a low-dose aspirin has been shown to lower the risk of having a heart attack or stroke in some people, it actually has serious risk of potential bleeding, and that can happen in the stomach, the intestines, and the brain. And that's according to this task force, and that's things that we've known for a very long time. And the other challenge, and that's why age is coming into this decision-making, say over or younger than 60, the risk of bleeding with the use of aspirin increases with age.
Okay, so what is then the new recommendation officially that they're reporting?
So the U.S. Preventative Services Task Force, this is an organization that convened to draft new recommendations, and they basically address the issue of, what are our concerns about taking daily aspirin for the prevention of stroke or heart disease? And that's what we're really discussing here is, we have always had this recommendation to take a low-dose aspirin, that's 81 milligrams, to potentially minimize the chance of a stroke or the consequences of having underlying heart disease. Oftentimes, Steve, heart disease can be very silent. So this seemed like a pretty innocuous, safe thing to do. And the task force convened, and basically now they are recommending through review of the literature, so this is evidence-based decision-making, as we say, that doctors no longer routinely start patients who are at high risk of heart disease on a daily regimen of low-dose aspirin. Now, low dose is 81 to 100 milligrams. The classic one is, Steve, the so-called Bayer aspirin that you see, it's 81 milligrams. And the proposed
They used to call that Bayer aspirin for children, didn't they?
Right. Yeah, now we don't, because there's a thing called Ray's phenomenon, which is where kids can have an adverse reaction to aspirin, because we use aspirin even following surgery on occasion in higher risk patients if it's indicated, but it's always by physician discretion to prevent the risk of blood clot. And we'll talk a little bit about how aspirin works, but even that potentially is associated with risks following surgery. So this recommendation is really based on mounting evidence that the risk of serious side effects can far outweigh the potential benefit.
Okay, so let's go back to the basics then. And Dr. Cole, tell us what aspirin actually does.
So, aspirin inhibits the formation of blood clots that can block arteries. Studies have raised concerns, Steve, that even regular intake can increase the risk of bleeding, however. So, you can argue that if it inhibits blood clot, right,
Okay.
stops bleeding, then you could be at risk for bleeding. And the area that's of significant concern is the digestive tract in the brain. And that danger actually increases with age. So while daily aspirin use might prevent or help prevent heart attacks and strokes in some people at high risk, you have to weigh that against the potential harmful serious effects of internal bleeding. I mean, because that too has obviously profound consequences if someone were to have a bleed either in the GI tract, gastrointestinal tract, or the brain especially. So there's no longer this blanket statement that says that, hey, everybody who is at increased risk for heart disease, or even though they've never had a heart attack, should be on aspirin, excuse me. So the task force is recommending that individuals age 60 and older should not take aspirin for heart disease and stroke prevention. And those between, and this is a very significant change, and those between 40 and 59 years old who have some risk for coronary artery disease or cardiovascular disease, but no history, should really discuss this option with their physicians. And what's interesting is even physicians have to get up to date with these recommendations. So this is not something that's taught in medical school. This is information that is now coming forth. And in fact, Steve, these recommendations were challenged even a couple of years ago, back when you and I were doing terrestrial radio on ESPN. We had a discussion about this, about the waning routine advocacy for an aspirin, and this now finally is formal recommendations by this task force. So those who are at high risk or some risk for coronary vascular disease or a history of stroke, that age range, 40 to 59, even though they may not be as high of a risk for a brain bleed or a stomach or a gastrointestinal bleed, they should discuss that option with their physician, and obviously making sure the physician is up to date with these recommendations. So the task force also noted that when deciding whether patients should start taking aspirin to prevent their first heart attack or stroke, clinicians need to take into consideration age, heart disease risk, and in a very objective way, and then bleeding risk. And then there may be some things that they can do to prevent bleeding, such as antacids and other things that can limit the effects in the gastrointestinal system. So it's gotten much more complicated than just saying, hey, it's super easy, not a big deal, take 81 milligrams, low dose aspirin, and you can reduce the chance of stroke or a coronary or a cardiac event.
I've always wanted to ask you. So back to internal bleeding. I'm fascinated by that because it's interesting. We've got all this blood in our body, but it's almost like it's in different compartments, right? I mean, blood can't
sure.
get out to certain spots. We call it internal bleeding. Then what is it?
Well, internal bleeding in this case is referring to really two major areas. One is the gastrointestinal system. So the mucosal lining is the lining of our intestines, our stomach, and so forth, and it's there to protect it. And because of the chemical pathway that, while it inhibits platelet aggregation or clotting by taking aspirin, it also inhibits these other pathways that can put the stomach mucosal lining, the protective lining, at risk. It compromises it to a level that you have reductions in protection at the same time. The risk that bleeding can't be stopped in a time-sensitive way.
Okay.
So when you look at the overlap in pathways of these agents, they can reduce our body's ability to prevent a bleed, and then in theory, once a bleed can start, it can't be stopped effectively because you can't clot. So it's not like your whole body starts bleeding. It's the gastrointestinal tract, which no longer has that protection, is now actually exposed to the inability to stop bleeding. And the second thing, Steve, is that the same thing it's trying to prevent, for example, a stroke from a clot, you could actually, in someone who has fragile vessels in the brain, could see the same phenomenon in the brain where you could get a brain bleed. And you can get a stroke by a different mechanism, from bleeding rather than a clot, which is what aspirin's trying to prevent. So it is obviously a complicated issue, and you're sort of fighting that risk-benefit ratio, which really puts the clinicians in the center of the decision-making.
All right, so it appears the latest is clear then, right? They don't want you to start a daily aspirin regimen, and for those who did, cut back, right? Or stop it, basically is what they're saying.
That's right, Steve. So, essentially the conclusions are that starting a daily aspirin regimen in people who are 60 or older to prevent a first heart attack or stroke is not recommended. And it's important to note that the task force recommendations are not for people already taking aspirin for previous heart attacks or stroke, okay?
Yep.
We're talking about those who are in a preventative mode. So those people who have had a previous heart attack or stroke should continue to take their aspirin unless told otherwise by their clinician, and that's a very important differentiator.
Not good for the aspirin companies, but important for the human life, right?
Yeah. I mean, when you look at the magnitude of the consequences of having an adverse event, such as a bleed in the stomach or a stroke, I mean, that's either life ending or life altering. So these recommendations by this task force have to be taken with serious consideration.
All right, so who makes up a task force? How is that comprised? And we always hear about these task forces. What does that mean exactly?
So a task force basically is often an assemblance, if you will, of experts in a field. And it's often people who have contributed to the evidence, who have done the research. And it puts them in the same room at the same time, where they may have contributed to the research that we use to make decisions. They could be clinicians who have real-life experience and clinicians who treat these patients. And it could also be basic scientists, PhDs, and even regulatory experts. So in this case, the task force includes 16 experts in disease prevention and evidence-based medicine who periodically evaluate screening tests and preventative treatments. And these are appointed by the director of a federal agency for healthcare research and quality. But the group functions independently. And in this case, its recommendations can help shape U.S. medical practice. So, for example, when we had issues with cardiac or heart concerns in the NBA, remember way back when we were worried about this concept of what we call cardiomyopathy or an enlarged heart. We had the Eddie Curry situation with the Chicago Bulls.
Yeah.
Some of that controversy came about because we didn't have a lot of information on what the value is of the MRI in evaluating the heart. Really sensitive test, shows its anatomy, but we didn't have any normative data on big people. And what the NBA did, to its credit, is they assembled a task force of world-renowned cardiologists and interventional cardiologists, people who do echoes, cardiograms, and MRI experts and so forth, and put them in a room, and they came up with a task force recommendation. Similarly, we have task force recommendations for blood clot prevention. For any very complex disease process where there's science coming from different angles in a multidisciplinary fashion, a task force is a wonderful way. It's a brain trust, if you will, to make an informed decision using not only real-life situations, Steve, but the evidence, what we say evidence-based medicine, to make intelligent decisions on behalf of me and you who might be at risk of doing something that otherwise might seem quite simple, in this case just taking an aspirin. Now, I think in this case, this task force, the guidelines that have been developed, they're not finalized yet. But once they are, they have the potential to affect tens of millions of adults who are at risk for cardiovascular disease. And that still, all the things we talk about on our podcast, cardiovascular disease continues to be the leading cause of death in the United States.
Okay, interesting stuff. Now, Dr. Cole, I want to ask you, after we take a tiny break here, how this new recommendation plays into what you do as a surgeon. But first, fall weather is here. Still time to get outside, enjoy your favorite activities, and spend precious time with family and friends. Aches, pains, or an injury should not be part of the memories you're making. The therapists at Rush Physical Therapy are there for you. With more than 60 locations throughout greater Chicagoland, Rush's clinical experts will get you back to life. Go to rushpt.com today and you can schedule an appointment. Not sure if physical therapy is right for you? You can request a complimentary consultation and discover the power of Rush Physical Therapy today. Vericel, another sponsor, develops, manufactures, and markets autologous cell-based therapies for patients with serious diseases and conditions. For more information about their products, visit VCEL.com. All right, we're talking about aspirin, and to wrap it up here, Dr. Cole, really interested to get your opinion as an orthopedic surgeon, whether it's the everyday or especially your recommendation following surgery. How do these new aspirin recommendations play into what you do?
Steve, I'd say that the biggest area that I have to deal with is the risk of a blood clot after surgery. And, the reason I never take a recommendation for surgery lightly, even though the surgeries themselves are very safe, is that, once you elevate the level of intervention for something, you invoke the other possibilities of, risk. So again, it's a risk-benefit decision making. So what I would tell you is that aspirin is commonly used, for example, and the only area in orthopedic surgery that has been investigated thoroughly is following hip and knee replacements. So one of the biggest risks after knee or hip replacement is the development of a blood clot. And we used to use Coumadin on a regular basis. And now
What does that
I
do?
will tell you that Coumadin is a blood thinner
Yep.
that works through a different pathway to inhibit platelet aggregation, meaning platelets coming together and forming a clot. And it was very hard to monitor. You had to take, daily or weekly blood tests to make sure that your bleeding time, if for lack of a better description, was correct. And there's been a number of new medications such as Eliquis and others that you don't have to follow bleeding times. But aspirin has been studied, for example, in hip and knee replacements and has been shown to effectively reduce the chance of a blood clot. What's interesting is that it's not only the blood clot, Steve, that's dangerous. It's the blood clot that can subsequently travel to your lungs, something called a pulmonary embolus. So surgical intervention can be associated with the risk of developing a blood clot, which has the devastating complication of throwing a blood clot to the lung called a pulmonary embolus. So when I do surgery, I have to weigh the patient's risks, the post-operative mobile. The number one reducer of risk of a blood clot, Steve, after surgery is getting up and moving around. So if a patient doesn't have a family history of a blood clot, we could arguably do nothing in terms of prevention with aspirin as long as they get up and move around. Most of the literature in blood clots and prevention with aspirin and others has really looked at hospital or what we call moribund patients who are hospitalized after trauma and things like that. In my world, it's really up to the clinician to make an informed decision as to whether or not we should put them on something post-operatively, because I've even had 16 and 17-year-old patients after routine surgery, even being on aspirin, develop a blood clot.
Wow.
So it doesn't necessarily prevent it, and it doesn't necessarily prevent a pulmonary embolus, a piece of clot traveling to the lung, from occurring. It might or could reduce the incidence of it, but it doesn't definitively prevent it. And then when you're in that situation, Steve, like anything, it just shows why we, as clinicians, medicine is a bit of an art as well as anything else. We have to take the totality of the information we have and say, look, this is the operation you're having. This is your post-operative course. You have or you have not any family history of a blood clot, or in yourself ever having a clot. You're not taking, on medication such as oral contraceptives or being a smoker or other that might put you at an increased risk. Weighed against, hey, I'm going to put you on aspirin, which could cause bleeding at the surgical site. Now, this is what's unique to surgery. Bleeding at the surgical site can happen with aspirin because it inhibits clotting. So that's a complication, and that's one you don't want to have because that could lead to an infection. It could lead to repeat surgical intervention. It could lead to increased disability and time off work and time off activities. So, and not only can you bleed at a surgical site by being on an aspirin, you can cause a gastrointestinal problem, a stomach problem like we just talked about, or even the risk of potentially for stroke where you could have a bleed in the brain. So you have to take kind of what you know in totality, and suffice it to say, Steve, there are because of the I guess wiggle room one has in making decisions in medicine in this exact area. We don't have documents that set the standard of care to say, this is what you do, Steve, after your shoulder surgery, you must take an aspirin. This is what you do after ACL surgery. It becomes a decision-making on the part of the clinician, and always, Steve, in something, when possible, consensual decision-making and discussions with the patient. But this is one where, facts reside in the clinical arena with doctors, and it's up to us to interpret that without actually having formal guidelines telling us what to do. That's why these recommendations on aspirin, Steve, the baby aspirin, not a baby, but a low-dose aspirin, are so stunning, because we've always just said, look, no big deal. I took one for a long time when I was training really hard for climbing. I just said, you know what, I'm going to do everything possible that's in my control. I'll start taking 81 milligrams.
It was recommended.
Yeah, at the time. And then, as I mentioned, years ago when you and I did that episode on ESPN, we talked about this, and I remember I was like, this is pretty amazing, because you never would have thought that there would be substantial literature that would show that, hey, just a little 81 milligram aspirin, which can potentially reduce the chance of a blood clot, is also associated with the chance to bleed in your brain or to have a catastrophic bleed in your GI tract that could cause you to hemorrhage and die. So it just shows you how complicated the world that I live in. I think the easiest thing that I deal with is, hey, Steve, you have biceps tendonitis, you have a rotator cuff tear, your kid has an elbow injury, tore his zonocollateral ligament, or he has an ACL tear. That decision is a lot easier than all the other things that go along with how we treat patients and medicine in general.
Absolutely. Great stuff, Dr. Cole. We appreciate it, and interesting topic. Now, to be your best, you start with best practices. Eat better, grow stronger, reach higher. Midwest Orthopedics at Rush, their work is what best practices are built upon. They're a team of leading physicians with the highest level of experience and training, prolific researchers delivering pioneering breakthroughs, orthopedic experts that other orthopedic specialists and their patients come to when they need individualized care. Get it done right the first time at Midwest Orthopedics at Rush. Visit rushortho.com/thebest. We hope you enjoyed today's Sports Medicine Weekly episode. Be sure to add the Sports Medicine Weekly podcast to your playlist on Apple and Spotify. Listen in anytime, any place. You can subscribe to the Sports Medicine Weekly podcast. New Sports Medicine Weekly podcasts are shared weekly on social media. Follow us on Facebook, Instagram, and Twitter. For Dr. Brian Cole and our producer, Alex Soroka from Midwest Orthopedics at Rush, I'm Steve Cashel. Thanks so much for listening. Hope you enjoyed the podcast.